when researchers ask people to self-blind actual microdosing versus inert placebo, there's no differentiation between the two groups. And there's no good evidence that true microdosing at 1/10 of it, sort of at that very low dosage, benefits people. But it's part of an intentional process. You wake up and you take your little microdose and you say, I'm going to have a good day today. And then you have a good day today.
Today, my guest is Dr. Alexander Belser, co-founder of the Psychedelic Research Group at New York University and a psychologist with 2 decades experience in psychedelic medicine. How did you first get into psychedelic medicine?
When I was a student in high school and even in college, psychedelics were extremely taboo. They were, I was a dare kid, literally signed a pledge, in elementary school, which is way too young for kids to be able to make consensual, contractual promises to themselves or others, that said I would never use psychedelic drugs. I'd never use any drugs of any sort. It was a sort of a Nancy Reagan program that's obviously fallen out of favor because there's no evidence whatsoever to suggest that it's helpful. And I came up in this sort of underground rave dance scene of the 90s where people were taking MDMA regularly. And MDMA in some jurisdictions wasn't even illegal yet. It had been, I learned later, used by therapists in the 70s and 80s who wrote letters to agencies saying, please don't take this medicine away from us. It's so helpful. And for me, that time exposed me to a different way of understanding how these types of medicines could be helpful, both to me and to the people that I was with. I was coming out of the closet at the time as a young gay man, in a time when that was, I was working through a lot of internalized homophobia. And, psychedelics were all Schedule I drugs. They were very esoteric, strange things that very few people seem to talk about, even though I came to learn that there was a very active, ongoing underground movement and that there was potentially going to be, leading clinical researchers at, tier 1 institutions, universities doing research on the topic. And so it was a sort of a funny, interesting time. Because there was so much misinformation, disinformation, vilification of psychedelic drugs, horror stories about all sorts of bad events that can and did sometimes happen, but really no attention to research and good practice for what some of the benefits might be when psychedelics could be used and had been used in supportive context. And so for me, it was an eye-opener. I just realized that the world was not as I understood it to be. And like many people, there was a sort of opening to a different way of understanding the nature of reality and to connecting to one another and to the body, to my history and to myself, my deepest self. And so it became something I was so curious about and so much more interesting than a lot of the things that we would be exposed to in school. I was just, it just seemed to blow the roof right off the rafters. So I was really curious about what might happen and where this might lead.
What was compelling about it for you? I mean, I've heard people say that it helped them find God. Did it help you find God, or was there something mystical?
I think that a lot has been made in the psychedelic world that people have a mystical experience or a mystical type experience. And I think that's actually a fairly rare experience. A lot of people take psychedelics in lots of different contexts, including in supportive research and clinical contexts, and don't see God, don't have face-to-face confrontation with the ultimate nature of reality, don't have an experience of the void, don't come into contact with some sort of like deeper, profound, mystical, religious experience. But some do. And for me, and for the people that I would work with, what we've learned is that at the right dose, in the right set and setting, with the right, I won't say right, but with a set of good intentions, psychedelic medicine is unlike other medicines. It challenges people to to be confronted with the things. Oftentimes the mind self-organizes even in a way that the mind is in conversation with itself. Psychedelic medicine brings to the fore things that we have not confronted And that seems to allow for the individual to really hit up against something that they've been sitting on for a long time. Sometimes it can be past trauma. Sometimes it can be a part of themselves that they don't want to admit as a part of themselves. Sometimes it can be realizing that they've been living in one room of their house, and that if they open the window or the door, there's a whole other vector of conscious experience that might be possible. Sometimes it allows them to drop more deeply into an ecstatic or relational experience, a mystical experience that's not just sort of the lone meditator on the mountaintop that has an experience of transcendent divine, but an experience of the real in relationship with others. This is sort of a feminist critique of what mystical experience might be, that we experience the real in loving, compassionate, deeply connected and attuned relationships with other people, and that can open our hearts and our higher awareness of what might be true. And in my work with psilocybin and with MDMA and with DMT and even in ketamine work in the clinic, people have these sorts of experiences. And I have to say, as a therapist working with them, it is an ennobling experience. It's also a profoundly humbling experience, because you can feel that something's happening for the person. They'll tell you, I mean, eventually they might share with you some glimpse of what they're experiencing, but there's a sense that something qualitatively is different than is happening in our everyday Monday through Friday reality, or even in everyday talk therapy. Something is different about this. And I think the jury is still out as to exactly what it is. We, as scientists, we try to pin it down, create the mystical experience questionnaire, do structural equation modeling to figure out which factors load onto which, factors, which items load onto which factors, and then trace that to correlate that through mediation hypotheses to symptom reduction scores for depression and anxiety and substance use. And all of that can be true, that the mystical experience does predict benefit for many people when they take psychedelic medicine across different indications. And yet, even when you look at the modeling, it only explains a small fraction of the total variability in scores. And the varieties of the mystical experience are far broader and bigger and richer. And unlike each other, it's not one thing. It seems to be many different things for different people in different phases of their process.
You mentioned that this is qualitatively different. You use that word qualitative. Your qualitative research is something you're known for. You had a big paper that was popularized by Michael Pollan, among others, in that book, How to Change Your Mind. Maybe from those interviews and things, what would be an example of an experience that one of your patients has had that's been so transformative?
Oh, well, I'm trying to pick one that might be illuminating or illustrative. There are many people that have never had what they consider a spiritual or religious experience. Maybe they grew up in a Christian household or came up in some religious tradition, but they never really felt it. They never had a felt sense that there was something more than meets the eye. And in fact, they would describe themselves as atheist or agnostic. And I was working with a patient once, and she and I had worked together for a couple of years, and she just kind of felt like the world was kind of flat, and she felt stuck in her life and really quite depressed. She had really refractory depression, meaning she'd been trying to work on it for many years, but felt really alone and disconnected and alienated and sad. And we worked up to a higher dose use of ketamine, which 95% of the time ketamine is given at sort of low doses to help people with depression or other indications. But we moved up toward a higher dose and used an intramuscular injection of ketamine, which is a particular type of experience. It's not like snorting ketamine or taking ketamine through an IV clinic. It's truly a psychedelic experience. And she asked if she could hold my hand, and she is in a room, beautiful room with flowers. We'd prepared for it. We'd set the intention. We played a soundtrack of moving, evocative music. She was wearing eye masks so that she could go inward, not look around the room, but go inward to her own to what would be attended to by her own inner intelligence, her own inner work. And as she held my hand, tears began to come down her eyes. She had the mask itself became wet, and she turned to me and she said something like, "This is where this is like where we've all come from and where we all go to. I've heard people talk about this. I didn't know that I could be there, that I could return to." And she didn't know how to describe it. It was ineffable. But she felt this profound sense of reconnection to something that was beyond the small self, beyond the sort of like anxious, vigilant, scared person trying to muck out a life in the world and in her relationships and work. And for that hour, she felt connected to a community of souls or spirits, and she made sense of it in this way. And I got to hold her hand, and I held her hand for the full time. And she felt solace and relief and an affirming sense that she didn't have it figured out, but that there was something more to what is than she previously even could suspect was possible. And she's still in some ways integrating that work, integrating that experience. It's not something that comes and you have an altered state of consciousness and then your whole life changes, because the next day you're back in the soup, mm-hmm. The cosmic soup, as Allen Ginsberg said. You're still in the grind. But this is the reason, these sorts of experiences are why many people are drawn to the promise of psychedelic medicine, and many therapists, including in places like Oregon and in our clinical research at NYU and Yale and at Cybin, have been drawn to facilitate and to create a space where these sorts of experiences might arise.
Mm-hmm. What do you think of these experiences? We talked a little bit about comparing things to sort of mystical experiences that people have with deep meditation and isolation and things. Is this just drugs? Is this just chemicals? Or is the meditation and the mystical experience on the mountain just chemicals? I mean, what separates it, or is it all the same?
Well, as Dennis McKenna says, we're all just made of drugs. I mean, literally, that's what contemporary leading research in brain, neuropsychopharmacology, and is serotonin, dopamine, cortisol. All of these are just drugs fluxing in and out of receptor sites in the brain, and they create phenomenal experience of what I'm not seeing you through this screen. The person listening and seeing this podcast is not actually experiencing me. You're experiencing, like Plato's wall, a drug created, and drug has this pejorative term, but like these incredible compounds which we create endogenously in the mind and that we can take into our body through food and medicine and other drugs to create this experience. And so I see it all as of a piece. I do think that there are many, and I'm a psychologist, right? So I'm a lay student of religion and comparative religion and philosophy, but my experience working with people is that there are many paths. Some of the leading psychedelic researchers are very interested in contemplative practices, mindfulness, meditation, lessons from the secularized sort of mindfulness lessons from the East. I say secularized because they come from mostly Buddhist and Hindu and other traditions, and there's a whole lineage of practice there, but also lineages of esoteric and community and ritual practices in American cultures, indigenous cultures, the ways in which psychedelic medicines are actually found on the 6 inhabited continents of the world, that there are literally many scores of both ancient and prehistoric and contemporary experiences of indigenous cultures using mushrooms and ayahuasca and DMT snuffs and datura flowers and ibogaine root all over the world throughout human history and time, to suggest that these are not outside of our culture, but are in fact deeply embedded in our cultural lineage, but that recent history, including the 50-year anniversary of the war on drugs announced by Richard Nixon, and continued to this day, has made it seem as though that they are um, out there, and I don't really understand them to be that. I see it more as potentially a reclamation of our human birthright to um, the full experience of consciousness. This question about with AI, what is consciousness? What is the nature of human experience? What constitutes consciousness? It's a question that reveals that non-ordinary consciousness is, I think, part of our human birthright, and that the human encounter with the divine, with ecstasy, the confrontation with death, these things are part of our human birthright, and that we can reclaim them. But I think our culture has lost sight of the forms in which we reclaim them, the practices that we hold them, the way in which we care for each other and contain them and support these through intentional process. And we have rituals in science and in medicine all the time. There's all sorts of rituals, and there are many of them are there for good reasons, for safety and efficacy. And I think part of the psychedelic medicine movement is learning from living traditions of wisdom, and also trying to make sense of how we can, from the inside out, change how we relate to ourselves and how we explore our own consciousness. And in doing so, come to know thyself.
Mm-hmm. And for you as a psychologist too, I'm wondering, so these experiences with the psychedelics, they sound maybe like a one-off or maybe just a few things, but people are also doing this as often as part of an ongoing psychotherapy program, right? So how does that mix in with the psychedelic experience?
In our program, so in our research, for example, at NYU, we started that group in 2006, and we and most of the university studies with psychedelics employ a psychedelic-assisted psychotherapy model, sometimes called PAP or PA psychedelic-assisted therapy. And it involves, when the research participant comes in, when the person comes in, they're paired with usually two therapists, and they have multiple sessions of preparation ahead of time where they learn about the study, they learn about some of the risks and the potential benefits of being a participant in the study. They establish rapport and safety and trust with the two people that they're working with. We ask them about their life, their background, big experiences in their life that might be relevant and important. And what we have found, and there's some good data to support this, is that the safer and the person feels, the stronger the bond of trust, the deeper the container, as it were, the psychosocial container. This leads people to feel safer in the medicine session itself, which comes next, that phase where you actually come in the morning and take, for example, psilocybin in a beautiful room with your therapy team. If you just dropped in on a day and took medicine, many beautiful things may and could happen, but the preparation is important to understand the sort of unique challenges of that person. And then we have the medicine session itself, which we can talk about. And then following that, we do integration. And integration has become a buzzword. It's almost become a meaningless word because it means so many things to so many different people. What does integration mean? In our work, we've developed a therapy model where we try to have a patient-centered approach, meaning different things are going to come up for different people. It's not a cog in a machine. People are not getting stamped out psychedelic experiences. They have radically different things may occur for them. And so they need a customized pathway to help both describe what happened to them, and they can do that with their therapists, and then also to help make sense of it and to make meaning of it and to integrate it into a story about who they are, where they've come from, and where they may go. And then to translate those altered states of consciousness, which may only last a matter of minutes or hours, into altered traits in one's life, into something that to marry that with their goals for what they want to do. If they want to make unique changes, they want to stop drinking, they want to be less depressed, less ruminative, they want to eat better, they want to be more connected to people in their lives, they want to pursue more meaningful work. Now is a good time to take advantage of an inflection point, because a critical learning window opens up, because we know that psychedelics have potentially neuroplastic properties. So a critical learning window opens up neurobiologically for people to give up old habits and to take up new habits. And we know that taking up new habits can be challenging for anyone who's tried to keep a New Year's resolution. But to do that in a relational context with people is really helpful. Now, many people pursue psychedelic medicine in the underground or alone, and there are many different forms of doing this. And I don't think there's going to be one set form for doing this, but it's not going to be like cannabis dispensaries. I think most of the regulatory framework, and I think some of the good clinical practice framework, was going to be that this type of practice, psychedelic medicine, will be held within a context of psychological support before, during, and after.
Mm-hmm. Yeah, so you mentioned that there's this window after of maybe greater neuroplasticity, and I've also seen you give presentations where you talk about there's sort of a black box. People take psychedelics, and then there's a black box where we don't quite know what happens, and then people have outcomes. What do you think is happening when people are taking psychedelics that's creating these changes that allow them to then have this neuroplasticity, that make these behavior changes, quit smoking, all these things?
Well, I'll tell you, as a clinical scientist, the jury is out. Mm-hmm. And I give a talk called Psychedelic Friction, where I talk about these major controversies, which is like something happens. We know in treating depression that the leading depression treatment, pharmacotreatment for decades has been SSRIs and SNRIs, but the effect sizes are very small, like on average 0.2, 0.3, which just means that on average there's less than about 0.3 standard deviations benefit for people who take the active treatment of Lexapro, let's say, or some other conventional antidepressant. With psychedelics, we're seeing, at least in the early trials, much larger effect sizes. The magnitudes are 2 times as big, 3 times as big, sometimes greater than 5 times as big. So much bigger shifts. And I would expect that to come down over time. But nevertheless, something is happening. And I think there's 3 different levels of thinking about it. There's a whole set of theories about psychoneurobiological things that are actually happening in the brain. Then there's a whole level of the psychological process, like things are happening in people's psychological processing before, during, and after in the psychedelic therapy. And then the third is maybe part of, some people would argue, part of psychology, but the mystical experience, what I think more broadly as RSMEs, which is religious, spiritual, and mystical experiences that are out of sync with the everyday happenings of life and tend to be trajectory points for people to make change and to have change scores on their depressive symptomatology or trauma scale, for example. And we can go through each of those if you'd like, but I think the jury's still out, because if we embrace a concept called complementarity, it may be that there are both things happening in the brain. For example, the DMN network going offline, I can talk about that, the enhanced neuroplasticity and the sort of adaptogen quality of psychedelics, 5-HT2A receptor, activation here with psychedelic work, which is very closely tied to serotonin. All of these incredible things, there's sort of a functional neuroconnectivity where different parts, literally regions of the brain, are firing and connecting to each other when they normally are sort of doing their own balkanized, isolated thing. So all of these things are happening kind of simultaneously, and they all seem to be potentially linked to benefit. Simultaneously, all these psychological processes where people feel a sense of self-compassion. They feel forgiveness for past hurts. They have they come out of trauma loops in the PTSD trauma for PTSD that has been dogging them for post-traumatic stress for oftentimes years or even decades. They have all of the beautiful things that can happen in a good therapy might happen through a catalyzing action of psychedelics, including just being seen by their therapist, which for some people is actually a very powerful experience and can be quite reparative, and has been shown in the literature to be at least as helpful as conventional psychotropic meds like antidepressant medications. So all of that can happen on the second level. And then we have the whole mystical experience thing, which frankly has not really been studied in the medical literature because other medical interventions don't give people reliably profound mystical type experiences. Now, I think that we're going to spend most of the rest of our professional lives trying to work out all of the different models. I do think that some of it challenges us to figure out what eschatological model we are using. Are we using a reductivist, positivist? The world is just cells and neurons and atoms, and it's just happening in the brain, and it's all about receptor activation. Or on the other hand, are we using like are people getting in touch with something in the nature of reality, which is actually beyond this world, that's immanent or transcendent or divine, or speaks to something that is profoundly true, but which cannot be shown or proven. And then there's this sort of like middle ground or combination ground where there's this whole terrain of the human experience that people get stuck, and then psychedelics may help them get unstuck. And so all of these things could potentially be happening in concert or in sync, and be correlated with each other. And as a scientist, it's exciting. It's also really frustrating because people want to be able to say, okay, you put the input in and then the output comes out. And that's actually not what we're seeing with psychedelics. We're seeing that individual trajectories of healing are quite different. And we can make sense of why that is in different ways. And they're all potentially, there's some good evidence to suggest that they may be true.
Mm-hmm. You mentioned the DMN going offline. Is that the default mode network?
That's right. Yeah.
And that's kind of the thing that keeps us all checking our phones and our emails and social media and stuff. How does that turn off?
So it's interesting, like if you put somebody in a scanner, usually they give people tasks. It's like, okay, now do this Tetris thing. Now like connect the dots. Now let's do this now do this memory sequence. But when they analyze the data, they're still continuously collecting data. And they found that the DMN, the default mode, what they called the default mode, was what was happening when people weren't between puzzle task 3 and 4. They had 5 minutes of a break. The administrator went to the bathroom, and they're just kind of sitting there in the machine, and they're still getting scanned. And so this default mode network, DMN, comes online, and it's associated, as you put it, with our self-concept. Some people associate it with the ego, although I think it's a little complicated. It's associated with reverie, with daydreaming, with self-referential concepts of the self. It's sort of what's going on when we're not doing other things. And when people take psychedelics, we see that the DMN starts to go offline. So our everyday experience of ourself, the world, sensation, our sense of identity even, there's a let up in that for some period of time. And because of this, people have pointed to the DMN as maybe and Robin Carhart Harris's work at Imperial really drives this home, like that may be the mechanism or sort of the thing that's happening, that to use sort of psychodynamic frame, that our sense of ourself, the ego, which functions to keep us to think of ourselves as like, I'm here. Most people think of themselves as like here somewhere, like I'm pointing to my my noggin, like my sense of self is kind of somewhere between the eyes and about an inch back. Like I'm kind of here, my feet are down there, and the person over there is over there, and the tree is kind of like in the field over there. But when the DMN goes offline, the sense of self becomes egolytic, loosens. It becomes less ego-rigid and more egolytic. And it allows for us to experience consciousness not as coming from this construction of a node that comes from here, but as in a broader spectrum. And so there's nice neuroimaging data to support that, and that might be a helpful way to think about what might be happening for some people.
And is that also like what happens when people have certain types of strokes and they feel out-of-body experiences? Is it similar? Is it different? Or is it like a flow state? I mean, it seems that there are different experiences that I've heard of besides psychedelics where maybe the DMN goes offline or that sense of the self being behind the eyes shifts.
Yeah, this has yet to be, I think, empirically rigorously tested, but psychedelics are not the only key that opens a door to a different frame of existence. There's some really interesting NDE, near-death experience literature, and some attempt to even collate written accounts of near-death experiences. People get into a car crash, or they're on the operating table. They have an experience maybe outside of their body. They may see their body. They may have a white light experience. They have, in some ways, many crossovers with the psychedelic experience, oftentimes a profound sense of a feeling of connectedness. They may feel a profound sense of unity, the interconnectedness of all things. They may have sort of an experience of profound religious, mystical import. And so, the problem is it's really hard to get the scanner on the person at just the right time. So we have these written accounts. And so there's some interesting linguistic analyses of people's trip reports on sites like Arrowhead, which collect people's psychedelic trip reports. And people will say, okay, I took, 100 milligrams of ketamine or 4 grams of mushroom, and then I had this experience, and they'll have 2,000 words. And so you can do sort of adaptive linguistic processing to look for similarities in people's trip reports, self-reports, including their NDE reports. And they have found, for example, this is of interest, I don't know that's definitive, that they can rank which substances most closely approximate the sorts of language and word used in near-death experience accounts and reports. And so there's an interesting paper about that online. I think they found that the ketamine experience outpaced, for example, 5-MeO-DMT or an NDMT or psilocybin, but only barely in approximating near-death experience. And I think that altered consciousness, non-ordinary states of consciousness can be attained through intentional practice, like meditation, sometimes very quickly, sometimes over decades. It can be attained through Kundalini awakenings. It can be attained through psychotic process, which I'm defining broadly to be thought thinking styles and patterns that don't make sense to the rest of us, and that can be oftentimes really harmful for people. I used to work in psychiatric units, but sometimes people with psychiatric processes are having profoundly beautiful experiences. It's not always painful or tortured. In fact, there's oftentimes a real rich and complex experience, and there may be some underlying set of factors that link these sorts of experiences. We just know that they are non-ordinary, and I'm curious to see what we might learn.
So something that came up in the Michael Pollan book was that there's psychedelic treatment for illness and things, but also that maybe for the betterment of well people as well. What does that look like?
So in the early days, when I was going to psychedelic conferences, I went to my first conference in 2001. Most of the psychedelic avant-garde movement in that time was not really that focused on psychedelics as a treatment for treatment-resistant depression, or psychedelics as a legal medicine for obsessive compulsive disorder. They were more interested in psychedelic liberty, in the exploration of consciousness and spirituality. They were more interested in less interest, not that there weren't important work happening, but there was as you put it, I think you're quoting Bob Jesse, who's he says, the psychedelics could be for the betterment of well people. And Bob Jesse is an Oracle exec who founded the Council on Spiritual Practices, which helped get funding and set up, and he was an original author on the Hopkins early psychedelic research in 2006 with psilocybin, which was with what are called healthy, normal, I'm using air quotes, volunteers or healthy volunteers, meaning people who aren't depressed, people who don't have generalized anxiety disorder, people who don't have an existing DSM diagnosis. And, the interesting thing about our culture is we don't fund that kind of research. The NIH, the NIMH, other organizations in Europe and abroad don't necessarily give multiple millions of dollars to fund treating and helping the betterment of well people. But there's this whole line of psychedelics that has been neglected because there's not really any money in it yet. And there's not necessarily money for it yet to sponsor this funding. But psychedelics as creative tools, it's almost canonical now that like Watson and Crick were using LSD at Cambridge around the time that they were discovering the double helix structure of DNA. And another Nobel Prize, PCR chain was discovered through the help of psychedelics. And there's been some anecdotal and rich anecdotal reports of, thought leaders and scientists working on creative problems that they take psychedelics and, like the inspiration of a song that drops into an artist's mind as though channeled, that they see the solution. And so there's this idea that psychedelics could be creative tools for well people. They could be artistic tools. Tim Leary, even, who has a complicated man, but thought that psychedelics could be part of the entheocognoscenti, sort of the thinkers, the writers, the poets, the political leaders might take these medicines as a way to better themselves and to better the processes that they were in. But there's always been another strain that psychedelics could be for all people in different, regulatory strategies or decriminalization strategies or legalization sort of frameworks. Mm-hmm. Most of the research in the last 10 years has focused on psychedelics for the treatment of specific conditions. It's usually called phase 2 research, people with depression, for example, which the FDA has granted breakthrough therapy designation of psilocybin as a treatment for both major depression and treatment-resistant depression, and MDMA, by the way, for the treatment of severe chronic PTSD. I was a therapist on those studies, and it's really promising as a clinical tool to help people who are qualify for a diagnosis. But a lot of the people who have depression find that psychedelics bring benefits to them in ways that they don't see as directly related to their, quote, depression. And so...
What is it then?
What is it then?
If it's not directly related to the depression, is it another aspect of their lives? Is it their relationships or?
Yeah, people come back and say, I'm able to talk with my wife in a way that I didn't even realize how closed I was to hearing her and to seeing what she was saying. And now I feel like I'm not fixed, but there was an opening that happened. People find a renewed passion for not just in activities they enjoy, like in depression, but they find that they reclaim parts of themselves that they put away when they were children because they thought that they had to become doctors or lawyers or business executives, but they end up, returning to the guitar because they like to make music. And, oh, by the way, the world needs music makers. So that's exciting. I think that in many indigenous cultures, and I'm not I'm really just a student here, but my understanding is that some indigenous groups would use psychedelics as means for divination, as ways of plotting battle strategy. I don't think that these are necessarily that psychedelics are necessarily like lean in any one direction. They are sometimes psychedelic as a mind manifesting. They're often described as non-specific amplifiers of consciousness. Non-specific meaning if you create a warm, nourishing, beautiful set and setting, that people tend to have warm, nourishing, beautiful experiences. But we know through the MK Ultra experiments that the CIA conducted, we know through conversion therapy where high doses of LSD were given to gay people to try to convince them that they should be straight, that psychedelics have and can be used in nefarious and malicious and harmful ways as well. And so they're not agents of good necessarily. I think it is really a matter of how we engage with them and with each other.
The phrase that I hear for that performance-enhancing use of psychedelics or that creative-enhancing use of psychedelics is microdosing. What is microdosing? Is that even a term that for you as a professional in this space you use, or what is it?
Yeah, so anyone who has ever even had a friend in Silicon Valley or gone to Burning Man knows about microdosing or knows something about microdosing. So people use microdosing in different schedules to clear the dross from life, to code better, to manage better, to manage their day with less coffee, to do all sorts of things. Now, microdosing is defined in various ways. There's different protocols, but one common protocol, and usually the sort of refrain is that if a conventional dose of psychedelics, like a moderate dose, might be 3 grams of dried mushroom. So a microdose is usually 1/10 or 10% of that dose. We have to be careful with language because actually there's different levels of dosing, and psychedelics are not scalar. Like if you change the dose, the quality of the experience can drastically change. So a tenth of the dose is really different, like a microdose, a true microdose, like for example, 10 micrograms of LSD, is different from an ultra low dose or a low dose or a threshold dose. Some people call these like museum floor doses or dance floor doses, where you're not having a full dose experience, but maybe you're having 60 micrograms, whereas 100 micrograms of LSD would be like a tab, a standard tab. I'm using quotes in a naturalistic setting. And similar to what people are conducting in randomized clinical trials right now, controlled trials. But then you also have higher doses leading up to, double that, triple that, people even going beyond that, which has been called both heroic doses, but I think also is potentially reckless without the right support, because your risk profile starts to, your benefit profile starts to sort of flatten out potentially, and your risk profile curve starts to amplify once you get the higher the dose goes up. Microdosing is usually considered a relatively safe activity. I think that there is some interesting research that it could have some cardiac valvulopathy issues, because most psychedelics activate 5-HT2B, which is associated with cardiac valvulopathy, which is the same sort of problem that got fen-phen off the market. I am not a physician, so I am not an expert in this, but there are some good articles online that explain the potential risk of this. And so for that reason, people with cardiac conditions should be very careful, but also it could be, people even without cardiac conditions could potentially be at risk. So it's not without risk, but people tend to take a very low dose. And from what we can tell, most people do fine, and they take a dose maybe every third day, for example, or they might be different protocols over time. And I'll just say one other thing. All of the research so far on microdosing, on true microdosing, I'm not talking about low dosing or ultra low dosing, I'm talking about like true 1/10 of the dose microdosing, is that it is incredibly beneficial for people in lots of different interesting ways. And probably all of that benefit can be attributed to the greatest, most tried and true benefit of all of medicine in all time, which is the placebo effect. When we do citizen science and when researchers ask people to self-blind actual microdosing versus inert placebo, there's no differentiation between the two groups, and there's no good evidence that true microdosing at 1/10 of it, sort of at that very low dosage, benefits people. But people believe that it benefits them, and it's part of an intentional process. You wake up and you take your little microdose, and you say, "I'm going to have a good day today," and then you have a good day today. It's a beautiful thing. And I think that this is one of the benefits of homeopathy, of a lot of supplementation, both sort of hippie supplementation. I mean that in a good way, but also sort of performance enhancing supplementation, which is that we can leverage the mind's ability to think that it's going to do better, and then the mind body does do better. And the placebo benefit is so powerful that it's more powerful than most mental health psychiatric drugs that we have on the market. And if we can figure out how to reliably utilize it, I don't see a problem with that. I think it's fantastic.
What do you think is going on when people experience the placebo effect? Because there are outcomes that can be pointed to it. So it seems there's some merit.
Yeah, well, the placebo effect is I'll illustrate this by discussing its antagonist, the nocebo effect, which is that if you give somebody a pill and say, okay, you may experience some nausea and some headache and some fatigue with this, people are more, even if it's a placebo, even if they're actually not getting anything that would be active that could in any way be thought to cause nausea or headache or fatigue, they are more likely to report that they experience these nocebo events, these sort of unwanted the inverse of the placebo, sort of unwanted side effects, even when they are not ingesting anything active into their body. And so, the idea that the body is some sort of an inert thing that you just sort of put a chemical into and then some outcome comes out is so ridiculous, because we know that the human mind is actively constructing reality consistently, including our own interoceptive perception of our gut, our nausea, or our experience of pain. We know that psychogenic pain and the experience and interpretation and the storytelling around pain is far more powerful than probably physiological experience of pain in and of itself. And people have real horrifying levels of real pain, but that the mind through placebo processes and other interesting processes is actually is quite a bit of an artist. It can create scenes and enter into them better than we could probably build around ourselves, and it's kind of mystifying to me. I mean, I get excited about it, but some of this is self-fulfilling prophecy. People think that they're going to do better, and then they do, and vice versa.
With all this talk of the upside and things, there's often the phrase "bad trips." What's a bad trip? Is that real? Is that propaganda?
Well, no, they're definitely very difficult, challenging experiences. The sort of proverbial bad trip, and I used to work in psychiatric ER in hospital settings, and people will come into the ER having taken all sorts of drugs. Usually it's polysubstance use, many different drugs, but oftentimes with psychedelics. And very terrifying things can and do happen. And so I think it's important, and it's incumbent upon me and everyone in the psychedelic research world to be really clear about this, that these are not panaceas, these are not cure-alls. Terrible things can happen at festivals. That's why there are, harm reduction efforts to support people in naturalistic settings. And there are many different steps that we can take to mitigate those harmful effects. A bad trip, though, is something that we write about in my work interviewing patients who've taken psilocybin. And I think that it's important to sort of put a little fork in the road. Psychedelics, about half the time when you're taking them, and this is what's been reported to me by people that I've interviewed in depth in many different studies, about half the time they seem to have very challenging experiences, very hard experiences. Sometimes we could think of this as ego dissolution experiences, periods of transient fear, anxiety, paranoia, profound worry. They feel like they are losing control of themselves. It can be really scary. I say transient because what happens is that these difficult experiences, they're also sort of confrontations with the self. Sometimes people think of it as the hero's journey, that you have to delve into the hell realms. Dante has to go into the inferno before he can rise to see Beatrice. These experiences are not uncommon. In fact, they are part and parcel of, for many people, the psychedelic experience. Many people do not just take a psychedelic and have a big, beautiful, bounteous, mystical experience. They go through this portal, this experience, and in fact, they may have to confront this experience in order to pass through into something else. They may have to metabolize something, trauma in the body, we know the body keeps the score, metabolize something that gets them through onto the other side. And in a supportive context where you've done your preparation, you feel safe and have a bond of rapport and trust with the people that are facilitating. You have a beautiful setting where there's all sorts of safety procedures that make you feel safer. People come through to oftentimes profound feelings of relief, affirmation, wholeness, beauty, sort of reclamation of the self. Bad trips, I think, happen when people have that difficult, challenging ego death, dissolution experience but they find themselves alone on the floor of a bathroom somewhere in at a concert where they don't know what's going on. They don't have support. They're afraid for their physical safety. They can't help themselves. They don't have someone there to help them. They don't have the right frame of set and setting. And so these become poorly resolved experiences where they enter into a period of anxiety and fear, and for good reason. And this can happen even in supportive contexts, but it seems to be less likely to happen in these contexts because we know from thousands of experiences in the clinic that the vast majority of people have very safe experiences, that they come through well when well supported. But bad experiences are psychedelic trips that are not properly cared for. And I think we have learned a lot. In the 60s, Eric Kast and others would put people in a room with doing psychedelic research and just kind of give them a dose of the drug and not give them any support and hope for the best. And most people come through okay. But we've learned that people probably require a little bit more hand-holding, and that some people may require a deeper level of support depending on that unique individual's needs. And lastly, I'll say, I think that the bad trip, when well held, can be a feature of the psychedelic experience. If you were to ask me, why do psychedelics work? Go back to the black box. Why do they get better? It's because we're not suppressing symptoms. It's not just like, okay, you feel depressed, we're just going to like push that down. People have to pull this up by the root, and they have to kind of do it themselves with support. And sometimes you don't like what you see when you turn over the rock. It's like there's something there that is been avoided, dissociated, hidden for a reason for some time. And it's with the benefit of psychedelic consciousness that we might feel large enough to approach it. It's with the benefit of a therapy team that we might feel safe enough to metabolize that trauma. And that's why I think that these difficult experiences may actually be not a bug of the psychedelic experience, but one of the reasons why, and a feature, why they're so potentially beneficial to people.
Mm-hmm. You touched on that phrase, the body keeps a score. I can't believe how many of my friends recently have mentioned the book by that title as well. I don't know much about it. What does that mean, and how does that play into the psychedelic experience?
So let me tell you by way of a little bit of a story. When I was interviewing people who had taken psilocybin in our trials at New York University, I didn't ask about the body. I didn't say, it wasn't like something that I really wanted to focus on or an area of interest. But people kept on saying, I had these incredible somatic body experiences. I had visions. One person had a vision of, this is a young man with cancer, a type of cancer. He had a vision of and a feeling, a strong experience in his chest of a black mushroom cloud of a sphere of cancer exploding and erupting out of his chest. One other person had the sense that their body was filled with something, and they would shake their hands and sort of the darkness would fall out their shoulders, down their arms, out the tips of their fingers, and they would physically vibrate it out of their body. People often with psychedelics are moving. They sometimes have inner visions of their corpuscles and their blood and the marrow of their bones and their ganglia. All these, they have inner visions of their gut, things like that. People have profound physical experiences. And what we have learned is that the mind is not really the mind is really the mind-body, and that the mind-body and the body and the soma in particular can be not only a site where trauma is stored. I think this is a helpful story, although it's more complex than that, but the body can also be a site of healing and regeneration. The old analytic sort of psychoanalytic model of therapy is that people have to have cognitive insight, and that the insight, and this is true for much of cognitive therapy, that the thinking is what is healing in some important way. But sometimes people go and dance for an all-night dance event and work something out and just feel better and actually work something out emotionally and historically in terms of their trauma or some abuse or some relationship with their parents or their girlfriend or boyfriend that is beneficial, and they don't necessarily have to have an entirely laid out insight-oriented cognitive frame. It works through the body. Sometimes when the body keeps the score, Bessel van der Kolk's work, people have, I mean, there's a whole book on this, so I don't mean to summarize it, but people will have things which happen to them, let's say abuse or neglect or really horrifying traumas, car crashes, battles in Iraq or Afghanistan, the death of a loved one in a terribly violent way. That it's so much stimulus in that moment that they just can't process it. So they're there, but they just kind of shunt it and dissociate it away. And sometimes that in psychedelic medicine comes through, and this is not just with psychedelics, but people will involuntarily sort of have shaking in the abdomen, or they'll have strong feelings in their legs or appendages. Sometimes it's in the jaw or the face. The different somatic things will sort of arise where this memory that was too much in the moment, it was dissociated, put away, compartmentalized. The mind may have done that to protect itself from this thing which was too much to manage in that moment, and other more important things needed to be done, like basic safety or just getting through. Now it can be that compartment can be opened up, and it comes out sometimes physically. It oftentimes has strong feeling. In the PTSD literature, and I've written about post-traumatic growth with a team from MAPS and other researchers, through the use of MDMA that leads not only to the alleviation of trauma, but also all sorts of forms of growth that can happen after a traumatic experience and after the healing of that experience. The body is a part of this. And I think that I'll say in my training, I almost got no somatic. I have a PhD in psychology, and I almost got no somatic training at all, very, very little. And I think most mental health professionals have been seeking this out, this sort of somatic training. And I think we're starting to learn that in the West, maybe in our culture, we think of the body as like as something that's there's shame and dismissal. But psychedelics seem to work with the whole person, or the whole person is invited to work with psychedelic medicine in a way that challenges our preconceptions about what is needed for individuals. And so I think a lot of study and training is needed for that, frankly.
Yeah, I'm surprised that that wasn't a big part of your training. I've heard you talk about this sort of holistic EMBARK model, which is an acronym, and the B in EMBARK is the body. That there seems to be this awareness, and I can't imagine how something so intense wouldn't need to be recognized with the body as well.
I think that the academy and the guild take a long time to shift, and it's part and parcel of our culture in deeply embedded ways. But one thing that I'm looking toward is where this goes. Like, what's the next generation of how we work with psychedelic medicines? What are psychedelic therapies? And so Dr. Bill Brennan and I conducted a survey, and we canvassed the existing approaches to psychedelic assisted therapies, and we cataloged 17 of them. And some of them are really sort of like conventional set and setting therapies. Some of them used cognitive behavioral therapy with like quit dates to help people stop smoking, like at work at Hopkins. People integrated acceptance and commitment therapy, meaning making, logotherapy, all sorts of interesting things were sort of cobbled together. And we looked to distill some of the wisdom of senior teachers and these existing approaches to see what was needed. And what we found was that a lot of these approaches were edict. They were taken from other experiences, even like religious experience, sort of the theological literature, and dropped down into the psychedelic experience, rather than emic, meaning coming up from the actual experience of what happens for patients who take psilocybin in this type of context to work on their depression. And what we came out with was what we hope will be a more integrative therapy that we call EMBARK. And EMBARK is an acronym that has 6 clinical domains, because it's not just one thing that changes. It's multiple different ways in which different people may arise, that may become emergent for a patient. And the E in EMBARK stands for the existential and spiritual phenomena that we know is important for many people. The M is for mindfulness, the sort of metacognitive way that we think about our thinking and come into non-judgmental, present-focused awareness. The B is for, as you put it, the body. The body is both a site of trauma and a site of healing, and so we need to incorporate the soma. The A is for the affective and the cognitive. We don't want to run away from strong feelings, from the monster. We want to trust, surrender, and let go, and even approach the difficult thing with psychedelics if you feel up for it, and pendulum in and out of that through a variety of techniques that we can work, the facilitators and therapists can work with the person. The R in embark stands for the relational. That means that actually sometimes healing is just in the context of being with somebody who is attuned to you. Your relationship with the facilitator, the therapist in the room, can be profoundly healing, especially under the sort of catalyzing experience of psychedelic medicine. But also what I realized talking to people is that their human relationships came up all the time. They saw in visions their mother, their father, the deceased lineage of their matriarchal or patriarchal lines. They saw their children that they'd been estranged from, and that was profound. And then lastly, the K in embark stands for keeping momentum, which is about preventing relapse. It's not just about going and taking medicine on one day, but it's about having an intentional process in preparation and throughout integration to set intentions and to set goals to translate altered states into altered traits over time, so that it's not just a blip in the well. We need to actually potentially change the channel of the current. And all of this is held within care cornerstones where we provide ethically rigorous, culturally competent, trauma-informed care, all within a collective care model. So it puts ethics right at the heart of the work, and it's a next generation therapy designed for the whole person, to allow for the very varying types of experiences that may emerge. And so there's a manual that we will be publishing soon, and we've published on this in Frontiers in Psychology if you're interested in reading about it. And our website, embarkapproach.com, I think will be going live later this year.
Well, with all of this stuff about psychedelics that's so compelling, what are the downsides or long-term side effects? Are there things like that people should be concerned about?
I think there's lots of potential downsides. I mean, some psychedelics, most psychedelics are not habit forming. In animal studies, traditional classic serotonergics like LSD or psilocybin, DMT, animals don't self-administer it, for example. So we don't believe that most psychedelics are addictive. There are some exceptions. Some drugs like ketamine can, and we know can be problematic for people, both in the community and potentially in the clinic, who may, it's not a highly addictive substance, but some people do form problematic usage habits with certain substances, and that can be true for any substance, really. I think that the risk with psychedelics is using them in ways that are non-intentional, where we don't attend to basic safety. I think that in a time when they are still Schedule I drugs, Class A drugs in Europe, I mean, it leads to people taking them in non-optimal circumstances, potentially, where they don't have what they might need to have a safer experience. And I think harm reduction is really important here. There are real risks with taking psychedelics, and they are not to be toyed with. And I think that they should be approached with respect and caution, and with a thoroughgoing process. And I believe that process is best held in a sort of relationship in a community of practice, a relationship with a provider, somebody who has trained and knows about this. I do think solo work is and has been beneficial for many people, but it's also potentially riskier. So I think that we are learning better ways to hold these practices. And I'm aware that most people who are using psychedelics are using them in settings that are not technically legal. And so I think it's important to do the research to find ways to for us to be able to use these medicines in the way that we use good medicine. And I look forward to that day.
Yeah. Well, for people who want to follow along with how you are using psychedelic medicine and doing all this great research and things, before I ask my last question, where should folks look for you online?
They can find me at alexbelser.com. And I also have a book that has come out called Queering Psychedelics: From Oppression to Liberation and Psychedelic Medicine, which is about the experience of LGBTQIA plus folks, sexual and gender diverse people, and culture in context with psychedelic medicine and culture. And there's some incredible chapters from 42 different authors in that book, so check it out.
Great. We'll put links to all of that in the description for everyone to check out. And Alex, my final question is, for those who are contemplating the use of psychedelics, what's an intermediate step that they could do to explore a little further?
Well, I would encourage people to look toward other practices that might help you get out of your head. And so I'm a fan of breathwork, intensive breathwork practices, specifically holotropic breathwork, and other schools like shamanic breathwork. If you work with a trained facilitator, these are legal practices that you can often find online. I'm a Kundalini teacher. I think that some Kundalini practices and tantric practices, I don't mean necessarily sexual erotic tantra, but like white tantra practices, and other forms of practice are ways to get out of your head. But and I think that there's nothing like dropping into the deep stillness of with the support of a sangha, of a meditation community for a day or a period of days. Talk about a confrontation with the self. It's certainly there for you if you let the mind quiet. These are not substitutes for psychedelic experience, but I think that they could be potentially beneficial and something to consider.
Mm-hmm. Just to follow up on that, I've done a session of holotropic breathwork. I'm curious, where does that kind of fit in on this getting out of your head? I remember a few things, but I remember my hands really clamming up. I think it was something to do with my blood chemistry and things. Some folks said they had emotional experiences, some didn't. How does that relate?
Yeah, individual mileage does and will vary,
Mm-hmm.
both for that person and a different day and with that facilitator in that moment. But breathwork is a way of access. It was developed by Stan Grof, a Czech psychiatrist who gave thousands of people legally LSD and later came to the United States and did research here. But when LSD was criminalized, he, with Christina Grof, developed holotropic breathwork, which is a way of accessing deeper, more intense breath over time. And I'm not a trained facilitator in breathwork, but I've done many works. And people do experience tetany, which is sort of experience at the appendages, like in the hands, which is safe and should pass for most people. But it can, for some people, occasion visionary experience, a non-ordinary experience, a different way of experiencing themselves. And, I encourage people to try different things. And interestingly, a lot of these more esoteric practices, there's not a huge PubMed body of literature on them, in part because the production of scientific knowledge in our culture is funded in certain ways towards things that would make a profit, like approved medication, for example. But there's not millions of dollars to fund things like holotropic breathwork. These are almost entirely philanthropically sponsored things. Shamanic practices, other forms of the artist's way, ritual practices. These are sort of things that people do on the side, but we don't necessarily have the money to figure out whether it would be helpful or not. So I'm more curious about them, and I'd be curious to hear how it works out for you.
Yeah. Well, Dr. Belser, thank you for having the courage to put your career into something like this, into something that is a curious space, and there's so much to learn, and I really appreciate you spending this time with me. Thank you.
Thanks, Brett, for having me. It's really a pleasure to be here.
Thanks for watching this episode. To help get more great guests on the show, be sure to subscribe.